Okay, hi everyone. Welcome back to another session with Fresh Dental Shadowing. Today we have Dr. Lee, and he's an oral and maxillofacial surgery resident at the University of Alabama at Birmingham. And yeah, take it away whenever you're ready, doctor.
All right. Well, thanks to Fresh Dental Shadowing for having me here. It's an honor and privilege to, share a little bit about myself and what I am currently doing down here in Birmingham, Alabama, as an oral maxillofacial surgery resident that was formerly trained or received his dental degree or did dental school at the University of Michigan. So I'll try to just go into my talk for today. That is my name, John Lay. I'm a maxillofacial resident. So what will be discussed today? So I'll briefly kind of go over introduction, a little bit about me, my education background, where I went to dental school, a little bit about some of the dental specialties that is available for students who are in dental school, what are available after dental school, and then oral maxillofacial surgery, what the specialty is covers or encompasses, and then we'll go straight into some case previews of what I have seen since I started down here in Alabama in 2018. And then finally, just a quick slide on some advice I'd like to give on for applicants in pre-dental or in for subspecialties or even for anything in life in general. And then we'll finish with Q&A. So a brief background on me. I was born and raised in Long Beach, California. It's in Los Angeles, California. Down in SoCal. I then went to University of California, Irvine in 2008, where I completed a public health sciences degree, after which I ended up going to University of Michigan School of Dentistry and graduated in 18. As you can see there, 18, the time between 2012 and 18 is a little more than 4 years. So I did take a gap year. I applied for dental school my fourth year of undergrad. I didn't really figure out I wanted to do dentistry until the beginning of my fourth year. And that was after kind of going into pre-med first and then changing my mind and becoming public health and then giving pharmacy a try and then also looking in a little bit into optometry. But I ended up going to dentistry because one of my close classmates and friends' mom is a general dentist, and I got the opportunity to shadow her at the start of my fourth year of undergrad, and luckily things worked out, and I ended up getting into University of Michigan in 2013. At the same time, I did take a year off between my third and fourth year dental school to do a research year at the National Institutes of Health for a year. Before coming back and completing my dental degree at Michigan. And then I matched into maxillofacial surgery down in Alabama in 18, to which I'll be finishing up in 2024. So what is dental school? Well, before that, I'm sure many of you guys know that there's a lot of prerequisites and requirements that I can't really remember right now off the top of my head, but it encompasses basic sciences such as biology, chemistry, organic chemistry, some math, some reading comprehension, some writing, and maybe some physics. I'm unsure. But other than that, that's just like the basics you need to complete in order to fulfill the requirements for an application. So once you know what you need to do, just work really hard, do well in those classes, and study your butt off for the DAT. I would say that's one of the most important exams for dental school, similar to the MCAT for medical school. So really work hard for that. But after you get into dental school, a lot of people think that, it's a straight line from first year to fourth year and you become a dentist. But what you really see when you start dental school is that you go all over the place, depending on what school you go to and the opportunities available, the friends you meet, the classmates you make, and the faculty members you interact with, as well as the rotations you go on. Once you start your clinical years in your third year of dental school, you will may change your mind on what type of dentistry or field of dentistry you want to go into many times. For me, I started dental school with a plan to basically get my dental degree and come back to California and work as an associate mentee for my friend's mom, who graduated from University of California in Los Angeles. But then after starting dental school at University of Michigan, I actually ended up really gravitating towards surgery or oral maxillofacial surgery, just based on the faculty and attendings and mentors that I made at the early start of my first year. So for me, it was a little rocky start in the beginning of first year dental school, but eventually it was a pretty straight line towards working towards getting into oral surgery. And dental school, similar to undergrad, it's very busy, it's very tough, but at the same time, it's only 4 years of school to become a doctor, to which you can practice right away. So if you can imagine, there's a lot of training, a lot of information you need to learn. So the first couple of years where you're in the class, you're going to be overwhelmed. It's going to be like drinking from our fire hydrant, where you really can't control how much classwork, how many quizzes, exams, and assignments you have to do. But on top of that, you also have to spend extra time in the preclinical lab there with those mannequins of practice, honing down and improving your dexterity or hand skills in drilling and using indirect vision, as well as really perfecting your skills on the mannequin before actually touching and treating real patients in life. So at the end of the day, it can be quite overwhelming, but just keep in mind that you're not the only one wherever you do go. There's a lot of other colleagues and classmates that are just like you, and you're in the same shoes as you are. So it may be stressful, but everyone's in it together. You are all one family, and by the time you do graduate, now you got a whole new cohort of very close friends and colleagues that you will keep in touch with and be good friends with throughout your whole life, likely. So then my gap year, so, why did I go to National Institutes of Health? Why did I decide to do this? Why didn't I just, move on and get into residency and start training? And so then I can eventually finish my degree and get into work and do everything. Well, for me, I never thought about doing research. Like I said before, I wanted to go to dental school and come back and just be a general dentist and work in California and, live nearby family and make money and everything. But coming to Michigan, it provides a new environment where not only did I want to be a surgeon, but I was also surrounded by a lot of very smart and very well-known scientists in the field of dentistry, oral medicine, and even medicine. So they provided me with an opportunity to first join a research lab, which was a benchtop, a lot of cell culture and things like that, but also animal surgeries. And I really got engaged in that. But if you can imagine, being in dental school, research is not something that every student has time to set aside for. So I wanted to give research a try to see whether or not I can do full-time research. So what this gap year was 100% research with no dental school. So I had a year off to go to the National Institutes. I'm basically a research fellow, along with one other dental student from he was at Tufts University at that time. So he and I were the only dental students. The rest of our cohort of, I believe, 50 or maybe 70 other students the rest were all medical students. So it's a highly competitive program. But, once we get in, every single student that gets in matches with a mentor, is assigned a mentor across the National Institutes, which has, I believe, 20 something or 40 something institutions covering various areas of medicine. And for us, dentistry, so dental craniofacial research. And that year pretty much composed of me just doing research every day. You wake up and you go to work, whether it be 9 to 5, 9 to 4, you just, it's all research. There's no clinical care. There's no didactics or anything. It's more of you're learning how to think like a scientist, design and propose projects, run experiments, test data, look at results, and then troubleshoot the results that may not come out the way you expect it to, and then figure out a way to adjust your hypothesis to better fit the purpose of your study. So it was a good year off, but that really confirmed whether or not I could do a career which was only science. And I really realized during this year that I needed to have patient interaction, clinical care. I knew that I needed a career where I was involved in research, but not only research, but also wanted the majority of my time to be allocated to clinical care, because I did miss a lot of the clinical interactions with patients and the kind of satisfaction you get from having the connection between you and your patient and treating them. So this was a good year off to really learn a lot and meet a lot of great people, make a lot of great mentors, and always have a connection to a great institution such as the NIH. But at the same time, I'm glad that it was only a year, and then I came back and finished my dental degree, and then I moved forth onto my residency training. So for pre-dental students, I guess you can look at, dental school covers general dentistry, just like medicine. It covers all these aspects that you see here. You will go through dental school. You will learn generally restorative dentistry, comprehensive dentistry, which includes a little bit of everything listed on this list here. And once you complete dental school, just like medicine, you can choose whether or not to continue your training to really subspecialize into an area of interest that you'd like to treat. So these are, from my knowledge, the current specialty options for those who are in dental school that are about to approach their last year of training and deciding to apply for additional training. The majority of the time, you do not have to do any additional training after you can graduate dental school in 4 years and then go straight into practice. You will be sufficiently prepared. You will have hopefully passed all your board exams and licensing to practice as a general dentist and just go ahead and start a job and make money. And that's what makes dentistry really attractive compared to our counterpart in medicine, because medicine, you do 4 years of medical school and you need at least 3 years of additional training, whether it be family medicine or internal medicine, to eventually practice after that. So a lot of the time, dentistry is attractive specifically because of the less amount of less amount of years to train before you actually go into work. So we'll start from the top. You have the option to do advanced restorative dentistry, and this is only 1 to 2 years more. It can range from a general practice residency, which most of the time is in a hospital setting. So you're treating more sick patients with more medical problems, complications that generally the dentists in your community may not be able to treat because they do not have the equipment and colleagues or medical colleagues or specialties nearby in the hospital to provide support if needed, as well as equipment or supplies such as sedation or additional equipment. Another option for advanced restorative dentistry is called Advanced Education in General Dentistry, an AEGD. And that most of the time will be, from my knowledge, at a Veterans Affairs hospital, a VA system. And with those type of patients, it's similar in that these patients are often a little sicker, but not too medically compromised. These patients are veterans. Obviously, if you're a patient at the VA, you're a veteran of the United States. And fortunately, they have pretty good healthcare coverage and dental coverage. So you will do a lot of complex restorative treatment, a lot of implant placement, a lot of crowns, bridges, restorative treatment, really comprehensive treatment where finance is not something that's limited, that will limit the care for the patient. Another specialty you can go to is endodontics, is basically root canal specialists. So these are the guys that really treat the sophisticated teeth with multiple roots and canals that a general dentist may not feel competent with or comfortable with doing. They usually most of the time will have a microscope to look down into the canals and really identify these tiny little accessory canals in the mouth. And I believe that's about 3 additional years of training. And then you got orthodontics. Everyone knows about orthodontics. Whoever has ever had braces or have seen Invisalign knows what an orthodontic is. It's 3 years of additional training. And then for that, they're going to do an additional training 1 or 2 years to subspecialize in pediatric cranial anomalies or craniofacial deformities. So orthodontics for very developmentally challenged patients or patients with facial deformities, and they oftentimes work with an oral maxillofacial surgeon for that. The fourth one down is periodontics. This is basically the gum disease specialist or the periodontal disease specialist. These patients, specialists will do procedures like implant placement. They will do gum grafting. They will do some oral surgery stuff, such as bone grafting, socket preservation. But strictly, most of their stuff are strictly only in the mouth or around the teeth and the gums. So they're all about saving the tissue around the teeth to save the teeth. And then the fifth one down is prosthodontics. This is the specialist that works with dentures, whether it be removable or fixed, bridges, crowns, really complex restorative dentistry stuff like full mouth rehabilitation. Say if patients have no teeth, they place 4 implants on the top or 4 on the bottom or more than 4, and they make really nice fancy crowns and bridges that are made from the nicest ceramics. Most of their procedures and costs for the procedures they do are very pricey. They can probably quote a full mouth rehabilitation to in the tens of thousands of dollars. So some of these patients they treat are on the higher end of the socioeconomic status. And their mouths or rehabilitation treatment plans could cost as much as like a car, a Tesla per se. And then for that specialty, they can even apply for a subspecialty called a maxillofacial prosthodontist or prosthetics. And later, when I run through the case reports, I'll show you a case that one of our maxillofacial prosthodontists that we work with did. And this has to do with not only the mouth, but they are the specialists of making prostheses or removable parts that encompass the head and neck. So they do prosthetic ears, nose, eyes, mid-face, that includes the nose, the eyes, even the dentures inside the mouth, or large upper dentures that fill a defect that a cancer patient may have after removal of a tumor. The next three are something that is not as well known. The specialty is available, but there's very few programs and not many students or many dentists that go into this. So an oral radiologist is basically a dental dentist that specializes in interpreting images taken in the head and neck or dental images. That's not it's available. I can't really think of any programs out in the United States that have this, maybe less than 5. The third and fourth one are pathology and medicine are often combined. So this is basically a pathologist, similar to medicine, but specializes only in oral pathology. So anything that we biopsy in the mouth or in the oral cavity, this is what they do. Same with oral medicine. So this is more of, they look at what's under the microscope. They're able to identify what the most common, what the lesion is, what the pathology is, and what is often treated, the non-surgical management of this oral pathology or oral finding. Dental anesthesiology is another subspecialty that one can go into. I believe it's about one or 2 more years. The only program I know of on the top of my head is Pittsburgh. One of my classmates I graduated with, he ended up going to that. I think he's practicing somewhere now. I get the attractiveness of this field is if they often are a traveling anesthesiologist, so they may travel from office to office providing the IV sedation or mostly IV sedation, oral sedation for the oral surgeon or the dentist to do procedures on more complex patients that can't do under just local anesthesia or just numbing. And then second to last is public health dentistry. This is more of a a broad field of dentistry. It's a little step back from clinical care. It's looking at population health in oral care. So these dentists most of the time will end up in administration or end up in Capitol Hill doing a lot of public service planning for access to care, access to oral care, dental coverage or dental insurance, part of Medicare and Medicaid. So they're working towards really improving and getting access, getting the public access to achieving or getting dental care. And then finally, oral maxillofacial surgery, which I will go into momentarily, which is now. So what is OMS or OMFS or oral maxillofacial surgery? Well, we're basically the specialists of the head, neck, and jaw. And all these points around the circles here are found on myoms.org. The how to get there on the bottom right, it's 4 years of undergrad, it's 4 years of dental school, and then it's additional 4 or 6 years of oral surgery residency training. And the only difference between the 4 and the 6 year track is just the 6 year has 2 years of abbreviated or shortened medical school. So I'm in a 6 year program at Birmingham, and I will have completed my medical school. I already completed medical school, but I'll get my diploma in June of this year. So basically, I have 6 years. 2 of them are medical school. The other 4 are oral maxillofacial surgery with addition of a little bit of general surgery somewhere in between and general anesthesia in between there. So it's a total of about 12 to 14 years of training after high school is what it takes to become an oral maxillofacial surgeon. And then after that, you can do 1 to 2 or even 3 more years of subspecialty training, which I'll talk about later. So what does OMS cover? So it covers lots of dental alveolar surgery, so oral surgery in the mouth, and that includes third molar or wisdom teeth management surgery, dental implant surgery, placement of dental implants in the mouth, upper jaw, lower jaw, extractions, which is non-third molar extraction, non-wisdom teeth extraction, any teeth that need to get pulled out, we'll do that. Treatment of facial injuries and trauma. This includes trauma or injury to anywhere from the top of the head down to the neck. Corrective jaw surgery, something which is very common in patients with sleep apnea who have anatomical structures, very thick necks, big jaws, big tongue, overweight, where we need to cut their upper and lower jaw and move both of it forward to open up their airway to help treat that. That also includes developmental or skeletal deformities, such as patients with an underbite, a severe underbite, or severe overbite that an orthodontist cannot fix alone. So what they do is they straighten out the teeth on the lower arch, the upper arch, put it into an ideal alignment for the upper and lower jaw, and then the surgeon will cut both jaws, 1 or 2 jaws, and move them into the new bite, and basically fixing their profile. If you look at that, the face there to achieve a fairly normal, based on calculations, a normal skeletal occlusion. So that's corrective jaw surgery. And then there's facial cosmetic surgery, and this includes rhinoplasties, nose jobs, blepharoplasties, eyelids, eyebrows, cheek, chin, facelifts, skin dermabrasion, lip fillers, Botox. That'll be cosmetic surgery. Treatment of TMJ disease, so joint disease, joint pain, trigeminal neuralgia, nerve pain associated with any of the nerves in the head and neck. There's a specialist for that as well. A lot of TMJ pain can be managed with medicine. It can be managed with exercise therapy, but when everything fails, then the surgeon would go in and do various types of surgery, whether it be a scope with flushing and steroids into the joint to help decrease inflammation from arthritis, or they can do surgery such as disc removal, disc replacement, joint replacement, or movement or reattachment of the disc if it is loose or dislocated. Down to the bottom, we have cleft lip and palate surgery. This area is more of a subspecialty. Most programs will not have training in this, maybe have a little exposure where we do hip grafts or bone grafts to patients, young patients or older patients with a cleft palate or cleft alveolus, so that we put bone graft in so that we can later replace it with a dental implant and tooth. Treatment of sleep apnea, which is the same as corrective jaw surgery, or remove the jaws forward. Oral cancer, oral head and neck cancer is also another subspecialty that requires additional training. This will be 1 to 2 years after. This is something I'm actually interested in. So treatment of oral head and neck cancer is a very complex field where patients with cancer, mainly over the oral cavity or anywhere in the head and neck, we treat with, surgery if that's indicated. If it's in a different area, such as the oral pharynx, we'll communicate with a radiation oncologist and our medical oncologist to look at radiation chemotherapy for that. So that covers, if not all, the areas of our specialty. And every program will cover every aspect of that. And the percentage of exposure and cases that each program sees will be different depending on where they are. But in order to be accredited, or in order to have a program be accredited to produce a competent oral maxillofacial surgery resident, each program will have to provide exposure of each of these specialties or each of these areas of training to a certain amount. So every program in the United States right now, I think it's about 100 oral maxillofacial surgery programs. All of them qualify. All of them provide sufficient exposure and training to their residents, with some having more exposure to trauma or cancer or cosmetic surgery or dental implants, third molar, or all the above. So where am I? Down in Birmingham, Alabama. If anyone's ever been to the southeast, it's a very warm year round. There's plenty of rain, plenty of hurricanes, good food, very humid, and the culture is very slow, very relaxed. Everyone's really nice down here. But since moving down here in 2018, I really love it. This is a great place to be. It's a big growing city compared to about 10 years ago. It's definitely changed a lot. It's a university that remains one of the number one or top rated diverse university, where a lot of students from different backgrounds and ethnicities come down to the University of Alabama Birmingham undergraduate campus to do their training. And it's rapidly growing. So even our residents, our graduate students, are coming from all over the country, and they're constantly downtown. It's putting up new restaurants, new breweries, bars, new hotels, apartments, and everything, because the city has actually grown a lot. And I think it's a great place for you guys, or any of you guys, if you're interested in applying to dental school, to look at UAB School of Dentistry. If you're in dental school, look at all our specialty programs in dentistry, even our medical school, if you're interested in medicine, our nursing school, our school of public health. Check it out. I think it's a great place to live. It's a great place to be, and it provides an excellent training opportunity. Okay, so we'll go straight into our case report. The first one is pretty straightforward. What you see in a typical outpatient or clinic. This was a patient I saw at the School of Dentistry in our oral surgery clinic. Otherwise, young and healthy gentleman. I believe he's 16 or 17 years old. He has, if you can see, that's a Panorex X-ray. It's an X-ray where they take an X-ray from the left to the right, and it flattens out their face as if they rolled their face on an ink paper. It flattens out like that. The patient's right is on your left, and the patient's left is on your right. And from what you can see, it doesn't look normal because you see more than the expected number of teeth. So if you were to think that, if you were to say that every patient has all their wisdom teeth, there'd be 32 teeth total. In his case, he has 3 extra wisdom teeth. So that's 32 plus 3, it's 35 teeth. So what he came in for was third molar removal. Now we're looking at 3 extra. So we got 1, 2, 3, 4 plus 3. So 7 wisdom teeth to take out. So that was a pretty cool case I did that day. Took out 7 teeth. It was kind of a challenge with the lower right side there because of the position of it laying or butting against the tooth next door. Some of these can be very challenging and complicated just based on their location. But that was a cool case to, I keep it in the back pocket or back of my mind to share it every year, I guess, to share it because it's a pretty cool one. You don't see this often at all. Next one is pretty common is dental implants. We placed it. This was when I was at the Veteran Affairs Hospital. It's one of the veterans we saw in the clinic. Photo at the top, we see he has a couple missing spots in the mouth. Looks like an implant was placed here prior, but he came in to see me to place an implant in the upper right or his upper right. So, put the highlighter here, laser pointer. His upper right here, and this should be slot number 5, tooth number 5, and then he was looking to put another one down here next to his existing implant in slot number 29. So what we usually do is we make pilot drill holes. We make a one small drill hole and we place a little locator or locator in there so we see, and then take an x-ray and we see whether or not the placement, our first pilot drill hole is actually aligned with the teeth next door. To make sure the distance between the pilot hole and the adjacent teeth are adequate. We don't want to put an implant in right away because if you're crooked and you're messed up and your crown's not going to be good or the tooth's going to be crooked. So after we do a pilot drill like this and it looks good on the x-ray, we just continue using slightly bigger drills until it gets the perfect size of the implant, and then we drop the implant in. We'll let it heal for about 4 to 6 months because if you put an implant into the bone, it takes about 4 to 6 months for it to integrate into the bone. Okay, so we jump straight to another implant case, but this is what I was mentioning earlier with our maxillofacial prosthodontist. So this patient had a history of multiple basal cell carcinomas or cancer of his nose that was invasive or advanced enough that actually invaded into not only his nose, but the substructure of his upper jaw, his maxilla right here, and his, I guess, nasal sinus and his maxillary sinus. So he ended up having a pretty big ablative or resection of the tumor, which involved his total nose. So it was a total rhinectomy. And a partial maxillectomy, a portion of his upper jaw was removed. And what we did is we placed 2 zygomatic implants. So these are dental implants, but they're longer dental implants, and they go into the zygomatic bone, so the cheekbones in the jaw. So if you can imagine, we can't put really dental implants into here because his upper jaw is actually really thin. So it'd be like putting a fairly decent sized implant into too thin a bone. It wouldn't be stable. So we have to use these really fancy long implants that go into the big, thick cheekbones in his upper jaw there. And then what our maxillofacial prosthodontist does is he makes a really fancy apparatus. It's like a locator attachment. It has a little magnet component to it, and it actually attaches to a connector which connects the midface or nose prosthesis here to an upper denture that he has in here. So it's pretty fancy. So we place these 2 implants, it becomes nice and stable. It's on osteo integrated in the bone. And then we give the patient over to a maxillofacial prosthodontist. He works them up, does a sweet impression, and then he waxes up a nice nose and lower right cheek and lower lid and upper lip. And then he makes a nice upper and lower denture, and then it snaps onto the nose and the upper denture. So it actually stays in fairly well. And the patient just wears it and uses it throughout the day. And every time he goes home, like taking off his shoes, he takes off his nose, takes off his dentures, puts them in the denture cleaner, puts his nose on the side of the bed, goes to bed, wakes up in the morning, puts it back on. So that's something that we do in our clinic here at University of Alabama. The next one is jaw surgery. So this is actually another VA patient we had that had sleep apnea, pretty severe sleep apnea, where his body type, where he was obese, had a very thick neck, and his jaws were just a little too far back. In that when you take an x-ray from the side, you see that his airway is really thin. So if you can imagine someone that big with a thin airway laying back and falling asleep, everything relaxes. So the tongue and the floor of mouth will drop back and it'll close their airway to a point where they can't breathe for a certain period of time or when they're asleep. So that causes them to, gasp for air and eventually wake up in the middle of the night, gasping for air. And that's pretty much what diagnosis, that's a clinical diagnosis for sleep apnea. Another clinical diagnosis or hint is someone who snores a lot in their sleep. But waking up in the middle of the night multiple times and gasping for air is a clinical diagnosis for sleep apnea. So what we did for him was We cut his upper jaw and lower jaw down here. Two cuts on his lower jaw and a straight cut on his upper jaw, and moved both of his jaws forward. At the same time, we also cut his chin and moved that forward. And what this does is by moving the jaw bones or moving the bone in the head and neck area, we're able to pull all the muscles attached to it. So if you move the upper jaw, it pulls your soft palate and uvula forward, opening up the upper airway. And if you pull the lower jaw forward and the chin forward, it pulls the floor, mouth, and tongue attachments forward. So by doing that, now his whole airway, upper and lower jaw, is moved forward and opens it more in order to treat or pretty much definitively treat his sleep apnea. So he doesn't snore anymore. He gets more sleep. Now he's better. And then this is one of our complex plannings for, this is like a combination of tumor surgery. Oh no, this is not tumor surgery. This is a procedure where this patient actually had a rare, uncommon complication where she had an upper jaw surgery to fix her bite. Excuse me. But unfortunately, after the movement of her upper jaw, just based on perfusion or blood supply to her upper jaw, it happened to lose supply. So her upper jaw, after being moved forward after the surgery, it ended up not surviving. So her upper jaw, all the gums and teeth, ended up dying. Unfortunately, it's rare. It's less than 1% that happens. I myself had double jaw surgery, and my jaws are fine. But in her case, she just happened to have very bad luck and just bad anatomy or something. But her upper jaw died, so we ended up having to remove her upper jaw. And what we did instead is we used complex reconstructive planning using virtual surgical guide planning to use her fibula bone, left leg bone here, to reconstruct her upper jaw. And how that works is we get scans of the patient, the head neck scan, the leg scan, and on a computer, we work with our computer engineers to virtually plan everything. So make the cuts on the leg bone over here, and then reposition those three pieces of the leg bone into the upper jaw position, as well as fabricate or design a custom made titanium plate that will fit specifically to that leg bone into her upper jaw that's currently alive and well. And we also plan in 6 implants at the same time. So on the day of surgery, we already have made or ran through the virtual surgical plan. We already have the surgical guides to cut on the fibula, there's the guide to place the implants on the fibula, as well as the custom plate in the upper jaw. So it basically takes away a lot of time in the day of surgery, where all we do is go into the operating room, we expose the area of upper jaw, make sure everything looks good, go down to the leg, get the fibula bone out, pull it out, cut it based on the guides into 3 pieces, put it onto this custom reconstruction plate, drop on the implant guide, and just put the drill through the holes that are already made on the guide. And then we just bring the whole unit, this fibula bone, implants, and plate, into the upper jaw, and all you do is fixate it in with screws here. And the bottom picture is basically what she looks like after everything's completed. So this dark skin right here is actually her leg bone skin. And this is her nice prosthesis right here. So this is her smile after the surgery. So she looks really great. If you didn't know she had this issue, if you just looked at her in public, it's really hard to tell. And this is something we did with our maxillofacial prosthodontist as well. Next case, cancer. This is just a very common cancer of the lower lip. It's often due to exposure to the sun. This patient came in, after obviously years of neglect, not really seeking care. And simple things like this, it's going to involve maybe about a third to half of the lower lip. And what we do is we remove the tumor down to where it's all negative, as in no cancer around the edges. And we design a fancy flap. This is called Bandonian flap technique. And it's just based on the Bandonian instrument that was present at that time. And based on the design of the surgery, you're able to move the pieces zigzag like that and close it primarily, or close it skin on skin, without really affecting the size of his mouth opening. So actually the outcome for this looked really good. This is another virtual surgical planning. This patient had a aggressive benign or non-cancer tumor of the lower jaw. We removed the tumor, planned everything on virtually, removed the tumor, and then used the leg bone as well. As you can see, this is the fibula bone, and this is the vein and artery that comes off the fibula that we take with it. And we hook the artery and vein up to the artery and vein in your neck up here, because since it's such a big amount of tissue, it has to have a blood supply to go with it to keep it alive. And this is the titanium plate that will connect this fibula to the jawbone. And this right here is just a printed model of her jawbone, or the patient's jawbone right here. This is an example of the printed 3D printed model, the surgical cutting guides in titanium, the simulated or printed fibula bone put in there. And this is the Pan-Rex X-ray of the patient when we saw them back in the clinic. So at a later point, we actually ended up placing a couple implants into the jawbone, into the new jawbone, and then she eventually got teeth down here. And this is just a bunch of other pathology, or whether it be benign tumor or aggressive cancer. Most of these are probably aggressive cancers, but this is just only a glimpse of the type of things that we do from teeth, small tumors, lip cancers, to really big aggressive tumors. First image you see here is pretty much a very gigantic aggressive ameloblastoma. It's similar to the tumor in this case, but in this case, it was, to us, this is not that big, even though I would say like a third of her jaws removed. This one is pretty much the whole jaw from angled angles removed and reconstructed with the fibula as well. This is an aggressive cancer that involved the neck, where this is actually the epiglottis and the voice box was removed. So in this patient, they had a laryngectomy. So they ended up having a permanent airway through their neck. This patient also had a very aggressive oral cancer where we removed the whole upper jaw, including the mid face. So this is actually the floor of the nose here. This is almost up to the cheekbone. And this is actually the nose is right here. And this is all the upper jaw and the upper teeth. This is also a whole lower jaw cancer right there. This is another ameloblastoma, I believe. This is a 3D printed image. You see how it affects the lower jawbone around the teeth. And finally, this is a patient who had a pretty aggressive cancer where a majority of the right midface was removed, including their eye. So for this specific case of here, she ended up having multiple implants into her facial bone, or their facial bone, and having a pretty nice big prosthesis. It actually looks pretty good. And then going into trauma down in Birmingham, we have plenty of trauma all the time. And, being an intern, being a resident here, you never get enough of trauma. So these are just some of the things we see. This is some of the things I saw and treated my first year down in Alabama in 2018. This is a case of someone being very fortunate, getting hit by a bullet, but getting lodged right in her nose. And we just went in and fished it out, and the patient went home. This is, very common motor vehicle accidents, the collision. So wear a seatbelt when you are in the vehicle. This is also a very lucky gentleman where a bullet glazed his face and he actually just needed stitches, no broken bone. Very lucky there. A young lady who got in a vehicle accident and the glass just sheared her scalp there. So all the way down to her pericranium, right above the skull bone there. And then hard to see here, but this is actually one of the facial nerves. It's called the frontal branch of the facial nerve, and it gives motor movement to their upper eyebrow to allow her to raise her eyebrow. Fortunately, the nerve was completely intact, so we just close her up, let her heal, send her home. This guy had a pretty bad ear injury. I think a pipe came down and slid his ear almost off. Fortunately, we were able to put it back together and actually survive. So that's some of the things we see. It happens all the time. Here at Alabama for maxillofacial surgery, we cover the head neck area trauma half the month, every month for the year round. And then I guess some final words I would say for advice for anyone and anything you do, anything you want to do, be curious, stay and be motivated. Everything's be self-motivated, remain curious, stay focused, always think about being better every day. Always try to learn something new every day. And at the end of the day, think about what you did this day and think about how you can improve tomorrow. And at the same time, you're thinking about dental school, you're thinking about medical school, pharmacy school, optometry school, whatever it may be, that's additional training after undergraduate. So technically you're going to be a lifelong learner. There's no end to learning. So just make sure you're lifelong learning, you stay curious. And at the end of the day, if the earlier you can identify mentors, advisors, and guides, it's very important, because these are the people that have been in your shoes a long time ago. And if they've been there before, they know what to do. They can provide advice. They can be their mentor. They can mentor you and guide you through the obstacles and the challenges that may come forward. And this is just a list of some of the mentors that I had that really impacted my life and really helped me get to where I am today. From all the people on the top are maxillofacial surgeons. The ones on the upper right here are the ones in my current mentors at Alabama. All the ones on top here are from Michigan. These are my non-oral surgeon mentors. He's current dean at Harvard. He's a research guide. These are my research mentors at Michigan. This is my research and oral surgeon mentor at NIH. These are a couple of scientists at the NIH mentors for me. And this is one of my close friends and guides at Michigan. There's many more, but just make sure that, everyone, think of yourself as a tree, and really you don't have, you're not you're not by yourself. The roots underneath the ground are the people that support you and help you become who you are as you progress through your educational training. And that's what I got for you today. So if you have any questions, I'd be happy to answer them. Otherwise, thank you for having me.
Okay, all right. Thank you so much, Dr. Lee. That was an awesome presentation and really interesting. So I think we can start with our questions now, if that's good with you, from the YouTube live chat and Instagram.
Okay.
Okay. So first question was, what initially drew you to OMFS rather than like general dentistry, or any other specialty?
Well, like I said before, I didn't choose on dentistry until my end of my third year. I was pre-med for the first 2 years in undergrad, and I was only pre-med because a lot of my cousins and family members were pre-med, and I thought it was just the thing to do. After going to undergrad, not really having a clear sight of what I'm interested in doing only because other people are doing it really doesn't help me stay focused. So I was really not focused during undergrad until probably the end of my third year, where my friend told me that his mom's a general dentist, go shadow her and give it a try and see if you like it. And fortunately, she was a very nice, very engaging, her personality was very kind, and it really just worked out. We worked out together, and I ended up being hired as an assistant for her, dental assistant. And while I applied for dental school, which is an extra year after fourth year, I just worked for her as a dental assistant there at that time. I studied really hard to do well in the DAT. I studied really hard to repeat any prerequisite courses that I need to do better in at a community college. And I did a dental mission in Panama for a week in the summer before I started dental school. So I was like pretty much ready to be a general dentist. Once I got to Michigan, I was ready to just go in, do well, and go back and be a general dentist. But at Michigan, our education is we start the summer. We're one of the few dental school programs that start in May of our first year, not in the fall. And our first summer, we start in head neck anatomy, probably one of the hardest class that we have in dental school. And in the head neck anatomy lab, we have a cadaver course, or cadaver portion of our didactic learning. And in the cadaver portion, they were led during our review session, it was led by two maxillofacial surgeons, actually three. I met Dr. Steven Feinberg there. I saw Dr. Joseph Hellman and I think it was Dr. Aronovich at that time. And their personalities were just, it was something that was just super engaging. It was very just, it's something you can't miss. It's something that their personality is just, you just wanted to be them. You wanted to be their friend. You wanted them to be your mentor. And from that summer on, I was just like, I want to be like them. I want to do what they do. It sounds great. So I ended up shadowing oral surgery as a first-year dental student quite early. And I ended up going into the hospital and into the operating room as a first-year dental student by September of my first year of dental school. So for me, it started very early without me knowing that I wanted to do oral surgery. But it was something I just kind of fell upon. And since then, like, even though I knew I wanted to do oral surgery, when I did dental school, even when I started clinicals my third year, I still liked some other aspects of dentistry. For example, I really liked prosthodontics, so I really enjoyed doing removable prosthodontics, and that's like dentures. And that wasn't because I liked doing the procedures. It was the people I work with. So the faculty members in my clinic that were prosthodontics, the way they interacted taught me, it was really nice. So I would say personally for me, the field and the things I chose were based on the people I met. I mean, obviously I enjoyed what I do. It's awesome. But if it weren't for these people who had a positive, I get a positive experience on my life, I think that I wouldn't have done that. So I think that at one point in my dental training, I actually thought about doing prosthodontics and oral surgery, which is kind of ridiculous. There's not many people like that. It just doesn't make sense. But I did think about that at one point. But I would say, I want to be a general dentist, and I decided oral surgery based on people I met, and here I am today.
Okay, awesome. And then also, so like once you decided that you wanted to do oral surgery, what steps did you take to make sure you got into the residency program, and like Like, what did you do to make your application stand out? Or like, were there any particular extracurriculars?
Yeah, okay. I would say if you were to get like straight down to cookie cutter basics, just like dental school, medical school, any grad school is very competitive. So if there's no specific formula that will get you in, but if you meet a certain amount of check boxes, you at least get an interview. So for dental school, it's get the appropriate GPA that is at average or above average of the accepted class every year, and getting the minimal volunteer hours to get an interview, and getting the necessary extracurriculars like, I don't know, like leadership and pre-dental club and that kind of thing. Same thing for oral surgery. Oral surgery is one of the very competitive specialties of dentistry, alongside orthodontics. Um, yeah, alongside orthodontics is pretty competitive. But for that, you need obviously good scores. So in dental school, if the dental school is still GPA, like Michigan, where I came from, then it will be based on your GPA. So if you had a very high GPA, that helps. And then based on your GPA, you'll get a rank. So if, say, out of a class of 100 students, you want to aim for the top 10 to 15% of the class, in the class. So that's another thing to work for. So mainly it's a lot about grades. All right. So after you get the necessary grades, what else do you need? Well, there's a test we have to take in order to be considered, and it's called the Comprehensive Basic Science Exam. And it's basically the same exam medical students take to practice and pass step one, which is the first step in getting a medical degree. That's a very hard test. It's a test that medical students take 2 years of didactic or clinical, 2 years of classroom training to study for and pass. And this is what the dental student has to do in, I don't know, maybe a year, study on their own time and do well and get the score needed to be competitive with all the other applicants in the United States, basically. So that's also very stressful. So that's the minimum. That's the scores you need. You need to do well in class, you need to do well in that exam. And now what do you have to do extra? Well, you have to do externships, is something they call. You visit, spend 1 to 2 weeks at oral surgery programs you're interested in. And this is pre-COVID. Right now you can't do it because of COVID. It's unsafe or whatever. It's eventually going to come back. But you spend 1 to 2 weeks at a program of choice. So I ended up visiting University of Pittsburgh for a week to shadow with their oral surgery program residents, get to know the faculty. And that's pretty much going there, shadowing them, assisting them, rounding with them, or seeing patients with them in the morning, staying with them until however late you need to stay to. You're basically attached to the intern or the resident's hip to show that you're engaged, you're willing to work and willing to be there. But you do it at least 3 different programs to get that on your application. And what you want to do is visit 3 programs you want to apply to and go to. So don't do it at programs you don't intend to go to. That's a waste of time and effort. All right. And then, so all these are mandatory. Okay. What can you do extra? So extra things would be research, which is what I wanted to do and what I was passionate about. So I was involved in the research lab. I did my NIH year, which helped a lot. And, I got a few papers published. So for me, research is something you could do, and it doesn't have to be related to oral surgery. It just has to be in something you enjoy doing. Other than that, I think it's a waste of time. If you're doing research just to have it on your resume, then when you interview and you talk about it, you don't know anything about it or you don't seem interested, and clearly the person interviewing you can see it. So don't do that. And then aside from research, you can take on leadership responsibilities. So if you're in dental school, either take a leadership position in the specialty program you're interested in. So there's like a pre-orthodontics club or a surgery interest group or something. So take a leadership position, be a president or I don't know, treasurer or secretary or something. So to be involved with that. You can be involved with non-surgery related student groups like community dentistry leadership, volunteering at community dental clinics with providing oral health education or cleanings, prophies. I was a part of, I forgot what it was called, Alpha Omega. It's a dental fraternity that did a lot of philanthropy things. We did a mouth guard clinic for special smile. So we did oral screenings for oral health education and mouth guards for special needs, at least 2 times a year. And eventually we ended up doing it 3 times a year, summer, spring, and fall. And that was a wonderful opportunity. I was really happy to do that. And it was amazing to see the same kids grow up a year every year. And it was very meaningful. It's good to have on our application. So those are just some of the things that you can do. But I think that for specific orthodontics and oral surgery, it's a very competitive dental specialty. And I think that one should really focus on getting the grades necessary and getting the numbers necessary to be considered. And then if you have the extra time, look at the extra things you can do, like the leadership opportunities or the research, if one is interested in research.
Okay, sounds good. And then someone asked if the dental school you go to matters if you want to pursue OMFS, and if so, like what factors should they look for in a dental school?
Not at all, not one bit. I think that some people, I mean, there's a general, you can go online and look at Student Doctor Network and look at you can just Google and look at I know, forums and stuff, and you can see that some dental schools happen to have just better matching rate for dental students into whatever specialties it may be. And that is based on mainly on the I guess the education. So for example, if you were to look at some dental schools, that the first 2 years of dental school in the classroom, the dental students take the exact same classes as the medical students, the first and second year medical students. I believe Harvard is like that, Columbia is like that, University of Connecticut is like that. That will better prepare a dental student who is interested in oral surgery to do well on the CBSE, the exam that all the medical students will take at the end of their second year. The dental students can take at the end of the second year. And they likely will do better, obviously, because they take the same class as medical students, they'll be better prepared. Now, does it mean that if you don't go to these programs, you can't do well on the test? No, it doesn't. I went to Michigan. We didn't have classes of medical students. I studied on my own time, my second year, my third year, and I took the exam multiple times. The good thing is you can take that exam as many times as you need to and apply with your best score. The downside is the exam is only offered twice a year. So if you can imagine, you can only take the exam twice a year. So if you were to study as early as a second year, then you can maybe take it 3 to 4 times before you apply, maximum 4 times. So what most students do is they may start studying their second year and take it at the end of their second year. So they got 1 there and they have 2 more tries to take it their third year, and they have to apply after that, unless they graduate and take a year off to study and then reapply the year after they graduate. So I think that one should not rule out or exclude any dental program based on whether or not you think your chance of getting oral surgery are affected. Because based on my experience and seeing the interviewees these past few years, a lot of them are outstanding applicants that match in oral surgery, and they're from these dental schools that are new, that don't have oral surgery residency programs at their school. So like I said, if you go to a dental school that you got in, that's great. It doesn't matter where you go. As long as you get in a dental school, that's, you don't have to get in the top ranked dental school based on based on some survey. You will be at your favorite dental school, your top dental school, at the one you accept the acceptance to. And then from there, you work on being the best student that you can be to make yourself a top applicant from your class. So I think that if you look at a number 1 student at a school 1 versus a number 10 applicant at maybe a fancier name school, there are many factors that play into it. But I don't think that the name of the school really has much. It has a lot to do with the scores, and it has a lot to do with your letters of recommendation, because those are the people that most of the time are oral surgeons that can vouch for you, that know you as a person, as an applicant, that the oral surgery program director will read and really take into consideration.
Okay. And then you mentioned that the OMFS program you're at was 6 years. And then I know you said the first 2 years are medical school, but can you kind of like break down what the other 4 years are or
Yeah.
after?
Yeah, sure. So, I mean, it's very complicated. It's very different at different places. I'm gonna just try to make it simple. There's overall about 2 years of medical school. The 2 years can actually be placed uh, near the front of the program. So, at at Birmingham, we do medical school our second and third year of residency. So I did an intern year, or my first year of residency was oral surgery. I was an oral surgery intern. I did only oral surgery, and I assisted in all oral surgery, and I was a part of the oral surgery department. And then at the end of my first year, I transitioned into a third year medical student, and I did my whatever requirements. I just joined the third year class of medical students, and then I continued on and finished with the fourth year class. And then after that, my remaining 3 years will include 1 year at Birmingham. 1 year is broken into 7 months of general surgery, and then general surgery is broken down into subcategories of general surgery, which include ICU, neuro ICU, surgical ICU, VA, etc. And then 5 months will be anesthesia, which is adult anesthesia and pediatric or kid anesthesia. And then our last 2 years, 24 months, are all back on oral surgery. So every program, whether it be a 4 or a 6 year program, must have at least 30 months on oral surgery. The rest of it can be however the program director or chairman or medical school wants it to be. Other programs like Michigan more recently changed to uh, their dental graduates starting medical school right away. They'll graduate dental school and they'll go straight into medical school and join whichever class they're joining, and they do the first 2 years of medical school, and then they go straight into general surgery for a year, and then their last 3 years are on oral surgery. So it's like you need about 2 years of medical school. You need about less than a year or a year, or a little more than a year in general surgery, and then you need a certain amount of time on anesthesia. And then every program will pick and choose certain points and mix it up. So overall, as long as they have anesthesia in there, as long as they have general surgery in there, and if it's a 6 year program, as long as they have medical school in there, then they can arrange it however order they like to. But I can't really go specifically because our program is not the same as any other program. Any other program is not the same as our program.
All right. Okay. And then how do you go about managing your time in dental school? Or how did you go about managing your time in dental school and like now in residency? Because I imagine it's really busy.
Yeah, yeah. I think that in dental school is going to really prepare you to learn how to manage your time very well. If you in undergrad took a lot of classes already, I don't know how many credits it is, but if you're taking a ton of credits and you happen to finish undergrad in less than the time needed, I'm sure that you are a very well managed, time managed kind of person. And I think the dental school for you will be not too bad. Um, uh, in residency for oral surgery specifically, it's a little harder because it's a different type of time management. It's like clinical care management, it's patient care management, as well as you have a little bit of didactics or learning lectures here and there, but no tests or anything. How I dealt with it was, I don't know, a little bit at a time. The first at Michigan, it was nice because our first semester on summer, we only had maybe 4 or 5 classes, two of which are super important, got to do well in. The other three are more light loaded, not as heavy and study intensive. So they kind of ease you into before fall hits, where you're taking 9 to 11 courses. So it kind of really teaches you how to figure out the best way you learn and study and allocate your time in the day for each course. A lot of students will have personal calendars they write on, and really allocate, what time of day they do, study for this class, study for that class. And then after hours, what time of evening or night or early in the morning before course they spend in the lab, the preclinical lab, drilling on teeth and stuff. So I think dental school is, personally, I think it's tougher than medical school because you're studying your butt off for lectures, exams, and quizzes, but then you're also practicing to pass your preclinical laboratory stuff like waxing teeth or studying dental anatomy or drilling or prepping teeth to pass that. So I think it's quite stressful. But at the same time, you can try various ways that you did in undergrad in dental school, but at the same time, you will also meet a lot of classmates that are similar to you, or some that have actually figured out that do really well with planning. And then you just kind of do what they do and pick up a little bit of what your classmates do and figure out what's best for you. So for me, it was just kind of learning on the fly and kind of choosing what I think is more important, what I think is worth most of my time learning. And a lot of the courses you'll see, like the scientific courses in molecular biology, biochem, those are important ones for your boards, your dental boards, and you focus on those classes. But like I said, once you pass the first 2 years of dental school, it changes from stress of looking at PowerPoints all day long and taking exams to basically learning clinical dentistry, understanding treatment planning, as well as providing treatment to patients and why we provide what we provide. And then finally applying all that for your final boards, your 4th year.
All right. Thank you so much, Dr. Lay. Those are all the questions we had. And yeah, we really, really appreciate your time and all your responses.
Outstanding. Thanks for having me.